In today's video, we're covering acute cholecystitis versus acute cholangitis. Patients presenting with right upper quadrant pain and fever are a very common situation clinically in the surgical practice. In this group of patients, acute cholecystitis and acute cholangitis are the most common diagnoses, but people very often get confused with the term. So in this video, we'll cover these two diseases and compare their differences. And to note the difference between the two, we have to first understand the pathology of both disease entities, and from that we could understand the difference in presentation in the subsequent workup and management. First, about the pathology. For acute cholecystitis, it is defined as the inflammation of the gallbladder due to the gallstones infections over the gallbladder neck or Hartmann's pouch. While for acute cholangitis, it is an infection in the biliary tract due to biliary obstruction. Gallstones are one of the most common etiologies, but it could be also due to other causes such as malignancies or other biliary tract stricture. So here from this diagram of the biliary system, you can see that the difference in the sites causes the different presentation in different diseases. If the gallstone is impacted in the gallbladder neck, then the gallbladder would be inflamed and it causes acute cholecystitis. If the gallstone is dislodged and block the common bile duct, then it would be biliary obstruction with bile stasis and thus infection in the biliary tract. For presentation, both of them present with right upper quadrant pain with fever. In acute cholangitis, there is also a component of jaundice. This is because of the biliary obstruction. Other symptoms of bile stasis include tea-colored urine and pale stool. So I know some of you have heard of the term Charcot's triad, so it's basically right upper quadrant pain, fever, and jaundice. And if it's combined with shock and altered mental status, we call it Raynaud's pentad. It just signifies a more severe form of acute cholangitis. And for examination, both of them have right upper quadrant tenderness. It's usually more florid in acute cholecystitis over acute cholangitis. And in acute cholecystitis, we have the term Murphy sign. Murphy's sign is elicited by asking the patient to take in and hold a deep breath while palpating over the right subcostal area. And upon inspiration, the liver and gallbladder would be pushed downwards, and when it touches the examiner's finger, it would cause severe pain due to the irritation of the peritoneum. And so if the patient experiences pain upon inspiration or the patient stops deep breathing, then it is Murphy's sign positive, which indicates acute cholecystitis. So when a patient comes in with right upper quadrant pain and fever, you have these diagnoses in mind. What we'll do next is we'll take bloods. The blood test, we have raised white blood cells in both of this condition as they're both inflammatory in nature. And for liver function, deranged liver function is uncommon in acute cholecystitis. ALT may be slightly elevated, but if it's severely elevated, then we may have to think of other diseases such as acute hepatitis. In acute cholangitis, the liver function is in what we call the obstructive pattern, which means that the bilirubin and ALP are elevated. This is due to the biliary obstruction. For both diseases, we would have to check clotting profile to prepare for intervention, such as surgery or drainage. We would also have to check for pregnancy tests in childbearing age women, because we may need X-ray or CT scan. We will need blood culture for both disease and possibly bile culture in acute cholangitis to guide antibiotics treatment. For imaging, ultrasound is the first line. Abdominal X-ray is not very useful. First, because only 10% of gallstones are radio-opaque. And second, even if we see gallstones in X-ray, it doesn't differentiate the cause. So we would go for ultrasound. For acute cholecystitis, there are 4 cardinal features on ultrasound. The presence of gallstones evidenced by posterior acoustic shadow, thickened gallbladder wall, pericholecystic fluid, and sonographic Murphy signs positive. And while in acute cholangitis, it will be dilated bile duct and bile duct stones. If ultrasound is equivocal and does not give us conclusive evidence, then we may proceed to CT scan or MRCP to better delineate the biliary system. Here, this is an ultrasound illustration of acute cholecystitis. This gallbladder shape and the covec shadow in the central of the ultrasound film is the gallbladder. We can see in its right lower aspect there is an hyperacovic oval shaped mass, which is the gallstone, posterior acoustic shadow. The gallbladder wall is thickened. Usually we take a cutoff of 3 mm. Above that we comment it as gallbladder wall thickening. And there is a thin rim of anechoic shadow around the gallbladder, which signifies pericholecystic fluid. And next we have an ultrasound film of acute cholangitis. What we show in the middle, the horizontal anechoic shadow, is the bile duct. For bile duct dilatation, we take a cutoff from 6 mm to 1 cm per decade above 60 years of age. Meaning that if you're 60 years old or below, your cutoff is 6 mm. If you're 70, the cutoff is 7 mm. 80 years old, the cutoff is 8 mm, and so on. And if patient had undergone cholecystectomy, we take a cutoff of 1 cm. And in this film, we could also see a CBD stone pointed by the yellow arrow. Management-wise, for acute cholecystitis, we would treat with emergency laparoscopic cholecystectomy. There are lots of studies comparing interval cholecystectomy versus emergency cholecystectomy. Current evidence suggests that there are no difference in the two groups concerning the perioperative morbidity and mortality, the operative time, and pain control. The only difference is longer hospital stay in the interval cholecystectomy group due to the second admission. So currently what we'll usually do is we take a cutoff of 5 days or 7 days. Before that, we would advocate for emergency cholecystectomy. After that period, the inflammation would have caused significant adhesions formation, which would make surgery difficult. And in that case, we would advocate delaying the surgery for a few weeks and perform an interval cholecystectomy for the patient. For those patients who are not surgical candidates, maybe with a lot of medical comorbidities, or those patients who have delayed presentation over 5 to 7 days, we would advocate conservative management with antibiotics. But if the patient remains septic despite antibiotics treatment, we would need to arrange drainage for the patient, either through percutaneous method with PTC or endoscopic method. But for acute cholangitis, we would need drainage to relieve the biliary obstruction. The first line would be with ERCP, which is endoscopic drainage of the biliary system. We could perform papillotomy, stent insertion, and stone removal with ERCP. If ERCP is not feasible in cases like history of Roux-en-Y reconstruction or B2 gastrectomy, or if ERCP fails, we will perform percutaneous drainage with PTBD. Other than drainage, we will need antibiotics coverage, and usually a prolonged period of antibiotics is needed for acute cholangitis. And don't forget that in this type of patient, usually the bile duct stones are secondary stones, which means that they come from the gallbladder. Thus, in patients with gallstones and in an episode of acute cholangitis, we will need to arrange elective cholecystectomy for the patient. So this sums up the difference concerning acute cholecystitis versus acute cholangitis from pathology, presentation, examination, investigations, and management. Hope you find this video useful. See you next time.